in anterior abdomen. At the other end of the spectrum, we have intestinal tympany, seen very commonly in puppies, secondary to eating ravenously. And usually these puppies manage to get rid of the air, albeit in a socially unacceptable manner. The presence of palpable fluid and gas within the abdomen can be an important clinical sign. It may point towards an intestinal gathering of fluid and gas anterior to an obstruction. Another useful pointer is it may be associated with enteritis, and this can be an important clinical sign, especially in the cat, because an owner may not be aware of what the cat is actually doing due to their secretive toilet habits. And if the cat is not using a litter tray in the house, they may not know what the animal is actually passing. So you feel the abdomen, and if the intestine feels very squelchy, full of fluid and gas, it suggests there is enteritis present. Another important clinical sign associated with enteritis in the cat is protrusion of the third eyelid. Now, this is quite a dramatic clinical sign which worries most owners. We don't know why it occurs, but is nearly always associated with diarrhea in the cat. Another pointer towards enteritis is the presence of scalding round about the anus. If an animal is presented with a distended abdomen, then the clinician is faced with a decision as to what is causing the distension and has to decide between the presence of an abdominal mass, fluid, fat, or fetuses. If we look at this diagram, we can see that if the animal has got ascites, then there is a pear-shaped abdomen with very little fat over the spine. If we look at the pregnant animal, on the other hand, then again we have a pear-shaped abdomen, but usually in these cases there is quite a bit of body fat over the spine. If we look at the obese animal, then obviously there is fat over the spine and it's a generalized distension all through the entire abdomen. If you do suspect there is fluid present, then a useful tip is to try ballotting the abdomen. And this technique is performed by putting the flat of the hand on one side of the abdomen and by tapping with the fingers on the other side of the abdomen. If there is fluid present, then you'll appreciate a fluid wave bouncing off the palm of the flat hand. If you do decide there's fluid present, then the next step is to perform paracentesis on the abdomen. An easy technique to perform, and will give you a tremendous amount of information by even basic analysis of the fluid which you obtain. Finally, let's consider abdominal pain. Now, abdominal pain can be very difficult to localize in both the dog and the cat, mainly because the abdomen is usually fairly small. Other reasons are that it's common to get referred pain. For example, dogs with an intervertebral disc protrusion may actually present with abdominal pain, although the lesion is within the spine. Other common problems which present with abdominal pain, although the lesion is not associated with the abdomen, are cat bite abscesses along the dorsal of spine and over the pelvis. The classical picture with anterior abdominal pain is that the dog will often adopt a praying position with its sternum on the floor and its hindquarters elevated in the air. Similarly, it's often said that animals with acute nephritis will show dorsal abdominal pain, that when one pinches behind the last rib dorsally, then the animal flinches if it has renal pain. In my experience, this is a comparatively difficult thing to elicit. Finally, posterior abdominal pain is usually associated with prostate or bladder lesions, and it's very rare in my experience to find posterior abdominal pain associated with uterine lesions. So in conclusion, abdominal pain is frequently noted, but it can be very difficult indeed to localize.
In this final section, I'm going to show you my approach to a skin case. The presenting history is probably as important, if not more important, than any other part of the clinical examination. It's useful to use a record sheet, such as the one shown here, which helps to remind the clinician to ask all the pertinent questions and helps to avoid missing out part of the vital history.
Certain facts must be noted down, including the age of the animal. Demodex is more common in young immature animals, while older animals are more likely to develop neoplasia, for example melanomas. Note the breed of the animal, because some breeds have particular predispositions. For example, West Highland White Terriers for atopy, Spaniels for seborrhea, and Boxers for mast cell tumours. Note the sex, because perianal adenomata are mainly seen in male dogs, whereas ovarian imbalance only occurs in females. There are a whole lot of questions you must ask the owner. When did the symptoms start? Was there a change in routine, for example in the diet or in the environment, prior to the clinical symptoms? What previous treatment had been given, and how did the patient respond to that treatment? Has the condition got progressively more severe? Does the dog have symptoms all the year round, or is it seasonal, or otherwise intermittent? Can the presence of lesions and symptoms be related to any change in the dog's routine? Is pruritus present, for example due to parasites or atopy? Is pruritus perhaps absent, as it is in hormonal skin disease? The aims of the physical examination are to identify the lesions and decide on their distribution over the body.
Whenever possible, a definitive diagnosis should be made before secondary changes have taken place or treatments have been given, for example corticosteroids, which may mask the underlying condition. You need to try and decide if the lesions are primary or secondary in nature. The common lesions that you're looking for include alopecia. Is the hair loss patchy, as it would be in ringworm, or is it bilaterally symmetrical, as in hormonal skin disease? Erythema, is it localized, for example on the ventral abdomen, as you would find in contact irritant dermatitis, or generalized, as you would see with a grain pollen allergy? Excessive scurf, as you would see with seborrhea, or pigmentation of the skin, which if melanotic is a response to chronic inflammation and is often accompanied by a thickening of the skin. Thinning of the skin is sometimes seen, for example associated with Cushing's disease. Abrasions are common and are usually due to self-trauma. And in hypersensitivity, for example dogs with flea hypersensitivity, often they're so sensitive that they resent having the dorsum of the back rubbed with a finger and the skin muscles contract. The physical examination is best performed in a brightly lit room, preferably with daylight. Brush back the hair to look at the skin. Does the hair look thinned? Does it epilate easily, as it would in a disease like Cushing's disease? Is there evidence of parasitic infestation of the coat? A small magnifying glass is useful to demonstrate lice, fleas or Chiletiella. If fleas are a problem, remember that they spend quite a lot of time in the environment or on another host, for example the family cat, so there may not be one on the dog at the time you examine it. Flea dirt, which is dark brown in colour, may give away the diagnosis, and these small specks of material consist of dried blood products, and if placed on a damp cotton wool will give a red-brown tinge to the cotton wool. Other parasites, for example mites, can only be demonstrated by taking skin scrapings or, in the case of Demodex, an epilated hair sample. Squeezing the site of the lesion will help to extrude Demodex onto the surface. You should remember that clinically affected dogs usually have large numbers of mites present. A few mites may be present in normal dogs. Using a wood lamp in a darkened room will help to demonstrate the presence of microsporan species of ringworm, but the test should be confirmed by microscopic identification, and you should remember that trichophyton species do not fluoresce, and some other substances may also fluoresce around the hairs, for example, tetracycline ointments.
Swellings of the skin are likely to be abscesses or wheals or tumours. Wheals frequently occur in large numbers on the skin and may be associated with gross edema of the jowls and lips and puffiness of the eyelids due to an immediate hypersensitivity reaction. Infection may be seen as pustules or as an area of wet skin with serum exudate on the surface. Large areas of hair loss with wet moist dermatitis are frequently seen near the tail base and often due to self-trauma from the irritation of impacted anal sacs. Self-trauma is common on the forelegs, resulting in chronic thickening of the skin called lick granuloma, which is behavioural in origin as it's caused by boredom. Tumours may be benign, for example this hemangioma, or malignant, as in malignant melanoma.
The likely cause of most cases of allergic skin disease should be evident from the presenting history and clinical examination. In some cases, it will be necessary to perform allergy testing or dietary challenges to confirm the diagnosis. In summary, the skin is a complex structure, and many cases referred to the veterinary surgeon will already be showing secondary changes or the effects of drugs that have been previously administered. By adopting a systematic approach to these cases, the chances of reaching a specific diagnosis is greatly enhanced. What Dave and I have tried to achieve with this video is to show you our approach to 4 different types of case. The first consultation is by far the most important. If you miss a diagnosis at that stage and start treatment, it may be difficult or impossible to go back and fully evaluate the case again properly. Nowadays, the public expect high standards of the profession, and increasingly they are not afraid to seek legal advice if they feel they haven't received the standard of practice that they're expecting.